Hi, I'm Dr. Sarah Cate. I'm a breast surgeon at Mount Sinai. I run high risk for the Mount Sinai hospital system. I'm also director of breast surgery quality. We're here to talk about all things breast cancer related, BRCA related, and breast reconstruction related today.
Hi, everyone. I'm Dr. Jordan Jacobs. I'm one of the plastic and reconstructive surgeons here at Mount Sinai. I am the site chief at Mount Sinai downtown, and I work very closely with Dr. Cate, taking care of our breast cancer patients. And today we're here to discuss a lot of the hot topics in breast cancer and breast reconstruction and celebrate Breast Reconstruction Awareness Month.
So some of the common questions that we get, we pulled together as a list and we'll be discussing those. So one of the top questions that I get as a breast surgical oncologist is who needs a double mastectomy? And that's a great question to ask because of course, when a woman is diagnosed with breast cancer, it's a very scary time. And patients immediately jump to the concept that if I get a double mastectomy or have both breasts removed, that my risk of recurrence is zero. First of all, that's not true, and not all patients need a double mastectomy. In fact, the majority of patients need breast conservation, which means to do a lumpectomy and sampling of lymph nodes. So patients that need a double mastectomy are a particular subgroup of patients that are diagnosed with breast cancer. Those patients include patients that have a breast cancer gene mutation, patients that have breast cancer in more than one quadrant of the breast, or patients that have bilateral breast cancer. A lot of times patients that have bilateral breast cancer can also undergo 2 lumpectomies and get radiated at the same time on each side. So it's a very selected group of patients, but it's something that you have to discuss with your breast cancer surgeon.
Great. Okay, I'll take the next question. So next question is, if I am BRCA positive, can I save my nipples? This is a very common question both Dr. Cate and myself get. And the answer is almost always yes. So we see Dr. Cate and I together probably see some of the most genetic positive patients, that is patients who have a genetic mutation that predisposes them to development of breast cancer. This lifetime risk can be as high as 85 to 90%. So these patients are screened it's high risk. And when we see these patients, and certainly when I discuss the reconstructive options, we certainly like to design a reconstructive plan that includes saving the patient's nipples. So whether or not that can be done in one stage versus 2 stages really depends on the patient's breast and how much ptosis or hanging of the breast they have preoperatively. Also determined by what size the patient ultimately wants to be. If you have a large breasted patient who wants to go down significantly in size, we have the benefit of performing a first stage breast reduction and lift. And we usually wait about 6 months after this first stage surgery before going back and performing the risk reduction surgery in combination with Dr. Cate. So that's a great question for patients to know the answer to.
The next question that we have is, can anyone get reconstruction on the same day as a mastectomy? And this is a very common question that patients come in with because it was much more common in previous years and in previous decades for patients to have 2 surgeries, one for cancer removal or removal of the breast, and then another surgery for reconstruction. So I'm proud to say at Mount Sinai that the majority of our patients get same day reconstruction, which means you go in, have your cancer removed, and get your breast reconstructed on the same day. And Dr. Jacobs and I work very closely together to provide that service to patients. So we have set days in the operating room that we work together, and patients, I think, feel very reassured that they can have their reconstruction, A, covered by insurance, which is a national law, and B, done on the same day. So there's very few indications where patients cannot get reconstruction. Some of those may be that a patient is too sick, for example, or has too many other medical problems to get reconstructed on the same day, and we're trying to make the surgery shorter. But the majority of patients qualify, and again, it's covered by a national law in the United States.
Great. Next question is, what is direct to implant reconstruction and who is eligible for direct to implant reconstruction? So first, what is direct implant reconstruction? Well, the answer is in the name. It is putting in the final implant at the time of mastectomy. So the breast tissue is removed by Dr. Cate. And at the same time, I put in the final breast implant, almost always a silicone breast implant. And we can talk about that further later on. It really allows patients to bypass at least one operation when it comes to their reconstruction. Not everyone is a candidate for direct implant reconstruction. I certainly counsel all my patients that, I certainly will do my best to perform direct implant reconstruction, but I will always have a tissue expander, which is the two-staged reconstruction on available just in case. The real decision of whether or not to perform direct to implant reconstruction relies on the quality of the patient's skin, and that can only really be determined after the mastectomy is performed. And things have gotten very technical and very precise now. And so we now have a machine that's able to measure the blood supply to the skin in real time while the patient is asleep after the breast tissue has been removed. And this is a critical decision making that allows me to decide if the patient can proceed with direct to implant reconstruction or if it's safer to place a tissue expander at the time of the mastectomy.
So the next question is breast reconstruction covered by my insurance. So that's something that I addressed in a previous question, but yes, there's a national law in the United States that reconstruction related to breast cancer has to be covered by insurance. So it's a common fear, and there have been studies that have been done on financial toxicity to patients that are diagnosed with breast cancer. And so this law was created in order to minimize financial toxicity to patients that are newly diagnosed with breast cancer, so that breast reconstruction is covered. It's covered the same day. Even more extensive reconstruction, like autologous reconstruction, which is tissue from your body to rebuild the breast, is also covered by reconstruction. So it's something definitely to inquire about when you're diagnosed with breast cancer.
Yeah, it's a really important point. I'd also like to point out that if patients need subsequent revisions over the years, those are also covered as mandated by federal law, as Dr. Cate said. Those are also covered by the patient's insurance. So whether a patient has implants and needs maintenance of those implants over the years, or if they just need touch-ups over the years, those are covered by insurance as well.
So common question that we get is, why should I choose breast conservation or lumpectomy over a mastectomy or vice versa? And again, this goes back to your genetic makeup. So if you have a genetic mutation for breast cancer, meaning one of the BRCA genes, your risk ranges from 40 to 60% or 60 to 80%, depending on the gene. So those risks are slightly lower for subsequent breast cancers, but most of those patients should undergo not only a unilateral or one-sided mastectomy for the breast cancer, but a double mastectomy. The other reason to choose a mastectomy over a lumpectomy would be patients that cannot undergo radiation following lumpectomy. So I always say to patients, lumpectomy and radiation go hand in hand, and we cannot just do the lumpectomy without the radiation. The reason for that is that radiation decreases the risk of cancer coming back to that breast by 50 to 70%. So it's really a prohibitively high rate of recurrence without radiation. Certain types of patients cannot get radiation after a lumpectomy. Those are patients with certain autoimmune disorders, patients with connective tissue disorders, patients that have been radiated before. You can't radiate the same breast twice, and your doctor will review this with you. Patients that also should not undergo lumpectomy are patients with disease in more than one quadrant of the breast. So when we're looking at a mammogram, we divide the breast up into 4 quadrants and we say, is there cancer at the top of the breast and at the bottom of the breast? And if that's the case, that's not safe to undergo lumpectomy.
And I'd also like to point out in regards to the lumpectomy surgery, patients are do have reconstruction available to them, some lumpectomies will leave a sizable asymmetry between the breasts, especially after radiation therapy. So our team works, taking care of a lot of these patients in order to balance them out after undergoing a lumpectomy. And again, this is a part of reconstruction that's covered by the patient's insurance. So important for these women to know that. Next question is, what's new in reconstruction? So a couple things I want to talk about. I think some hot topics are certainly perforator flaps. The one that's probably most known is the DEEP flap, or deep inferior epigastric perforator flap. That's basically doing a tummy tuck, that is taking the skin and fat from the lower belly, below the belly button, leaving all the muscle behind. It used to be that the skin and fat was taken with muscle, but we know the anatomy much better now. We have imaging to look at the anatomy, and so we're now able to spare all of the patient's core muscle in their lower abdomen. And so perforator flaps, that is taking the skin and the fat with the main blood vessel that supplies that tissue, and transferring that up to the breasts, where we reconnect the blood flow, has made it a lot easier for patients to recover from this type of surgery. So I really tell patients that the recovery from the DEEP flap is very similar to the recovery from an abdominoplasty or tummy tuck. Other perforator flaps where we use across the body are usually from the inner thigh or from the upper posterior thigh. We really like the donor site to look good as well, not just the breasts. The other things that are hot topics in reconstruction are nerve reconstruction. So we still have a long way to go, and this is still in its experimental phases, but Mount Sinai is one of the institutions that's involved in this research. But we have figured out that we can reconnect nerves from the patient's intercostal nerves that ultimately supply the breast skin and nipple, and we can reconnect it to nerve grafts, and then ultimately up to the patient's skin. So again, this is still in the research phase, but Mount Sinai is one of the centers in the country that is leading this research. The next question is, what is a DEEP flap? And I really already answered that. It's basically a tummy tuck. And instead of throwing out that skin and fat that would come off in a tummy tuck, we use it to reconstruct 1 or 2 new breasts. Patients usually choose this type of reconstruction, which is called autologous reconstruction, just because it looks and feels a little bit more natural than implants, but it does have the scar either across the lower belly or in the thighs. So that's the trade-off for this type of reconstruction.
Okay, next question. Do all breast cancers need surgery? So this is definitely a hot topic. There's a national clinical trial called COMET, and that's looking at patients with certain types of DCIS, and they get randomized to no treatment at all versus standard of care treatment, which is surgery, radiation, and anti-estrogen pills if you need it. So we'll be looking at that over the next few years. The trial is still actively enrolling, and we at Mount Sinai are a center for recruitment for that trial, which is run through a national cooperative trial group. There have also been trials looking at patients that get neoadjuvant chemotherapy, meaning chemotherapy before surgery for HER2-positive disease, and then rebiopsying that area and seeing if they don't need surgery. None of this is ready for quote unquote prime time, and none of it is standard of care. So outside of the setting of a clinical trial, we're not ready to avoid surgery for breast cancer. But again, a very hot topic.
I'd like to talk quickly about implants, because there's been a lot of reports in the media about the safety of implants. So I'd certainly like to speak to that. We do know about an association of a type of lymphoma called anaplastic large cell lymphoma. So that's a type of cancer that is caused by implants that have a rough surface to them, also known as a textured surface. The thought is that it's some type of immune response that's elicited by the textured surface. And the incidence is very low. It's about 1 in 20,000 women. And the lymphoma is almost always curable. But here at Mount Sinai, we certainly do not use those textured devices. But patients still should know about this when they consult with their plastic surgeon about the types of implants that are going to be used. So we use smooth implants, which is the other option. Almost all patients choose silicone versus saline, just because silicone feels and looks a little bit more natural. It also ripples a little bit less. And as far as smooth silicone implants, these are safe. As far as we know, there was a report, a media report put out by the FDA about very small incidence of a type of skin cancer called squamous cell carcinoma associated with breast implants. But right now, that data is way too preliminary to make any conclusions, and the incidence of that is extremely low, something like 1 in a million cases. So these implants are widely available on the market. They've been extensively studied, and we continue to study these implants. But as far as we know, they are completely safe, and we use them on a daily basis.
So another common question that I get is who needs genetic testing? And the indications and insurance coverage for genetic testing have greatly expanded over the past few years. So the indications for genetic testing are very widespread now. Most patients with breast cancer are able to get genetic testing now because it is covered by insurance. People that really need it are people that are young that get breast cancer. So anyone under 50 should get tested for the BRCA gene and then for other genes. People that have family history of breast cancer. So if your mother had breast cancer, especially if she was young at the time of her diagnosis, you should definitely get tested. If you have a sister with breast cancer, if you have more than one relative on the same side of the family that had breast cancer, and then patients with family history of ovarian cancer, especially. So 30% of serous ovarian cancers are linked with a BRCA mutation. So it's an important red flag for us. But there are many other indications, patients with colorectal cancer in the family and different types of cancer within the family. So it's an important question to ask your primary care doctor. If you get diagnosed with breast cancer, your breast surgeon will send you for genetic testing. But it's often something that we see that many patients are coming in diagnosed with breast cancer and maybe should have had genetic testing a few years earlier so that they were screened more aggressively.
Great. I think that's it for our questions. I would just like to say that I'm honored to be part of this team, to get to work with Dr. Cate and the rest of the physicians at Mount Sinai. And I would just like to send out a special salute to all our just brave patients, the many women that have gone through this journey and come out on the other end. We really we applaud you and we salute you, and thank you for allowing us to be part of your care.
And I agree. So I think one of the best things about working at Mount Sinai is the other doctors. So any day that I get to spend with Dr. Jacobs in the operating room is always a day that we take really good care of patients. We work really well together. And I think patients feel that the care before surgery and after surgery is really seamless because we are such a good team. And being a breast cancer surgeon obviously is extremely humbling because you see patients dealing with horrible situations and sometimes not great prognosis every day. And it just reminds me every day of why I became a surgical oncologist and why it's so important to provide excellent care.